Well, before we get started, I'll need to share that there is no commercial support for today's program. Any financial relationships of the planners and speakers with commercial interest has been mitigated. Today's session was awarded CE credit for physicians and for nurses. A link to the evaluation will be passed out and posted in the chat. If you are ABS certified and want NGHS to report your CME credits to ABS, please fill out the evaluation and give us permission to do that. If you have a question for the presenter, please hold until the end of the talk. If you are attending virtually, you may enter your question in the Q&A section. And now it is my pleasure to introduce our speaker. Dr. Sean Higgins is currently a PGY5 general surgery resident at Northeast Georgia Health System. He was born in Los Alamitos, California, but mostly raised in Chicago, Illinois. He attended Tulane University, obtaining a master's degree in cell and molecular biology prior to attending the University of Queensland Ochsner Clinical School in Brisbane, Australia, and New Orleans, Louisiana. His first 2 years in surgical training were at the University of Texas in San Antonio prior to coming to Northeast Georgia Health System as a PGY3. He is planning for a career as a trauma surgeon and is continuing his medical training in surgical critical care at Memorial Health University in Savannah, Georgia in 2026. Please join me in welcoming Dr. Higgins.
Good morning. Thank you for that introduction. Today I'll be presenting on blunt chest wall injuries, the history of them, contemporary management, as well as a case-based approach. I have no financial interests or commercial interests, unfortunately, other than being a resident. The historical background of chest wall trauma dates back to Egyptian medical texts, further described by Hippocrates, prior to the great advancements that happened in the 20th century with the introduction of non-operative management and surgery. As well as the introduction of cross-sectional imaging in the 20th century. The first known description or medical description of chest wall trauma or rib fractures comes from the Edwin Smith Papyrus. It was a papyrus purchased by Edwin Smith in 1862 in Luxor, Egypt, prior to being translated in the early 20th century. It's roughly 36 centuries old, so it's fairly old. And it's a case series of traumatic injuries as well as other surgical cases. Interestingly enough, there's a few that describe chest wall trauma and rib fractures. Case 44 describing an open rib fracture, stating one having a break in the ribs of his breast over which a wound has been inflicted, an ailment not to be treated. So recognizing the severity, almost 40 centuries ago of chest wall trauma. They also describe another case of closed chest wall trauma, stating that thou shalt bind it, thou shalt treat it afterward with honey every day until he recovers. Describing an external splinting device to treat chest wall trauma to try to stabilize the rib fractures. Hippocrates in the 4th century further described chest wall trauma, and he described hemoptysis with rib fractures, recognized the underlying pulmonary contusions and the seriousness of those injuries. He recommended wrapping the chest in linen for 20 days if there was no evidence of underlying pulmonary injury, and then 40 days if there was. And that is essentially the management of chest wall trauma for the next, 24 centuries. We really didn't make any great advances until the 20th century. In 1902, John Hoyt described the first artificial respiration device in which he applied a piston to a rotating device that sucked air out of a tank and then provided it through tracheostomy tubes that were attached to animal models. This wasn't used in medicine, or at least to treat chest wall trauma, for another 50 years. Carter et al. In 1951 were the first to describe the use of mechanical ventilation for internal support for rib fractures. It was a case series that described the use of tracheotomy as well as intermittent mechanical ventilation in traumatic rib fractures, mostly flail chest and unstable fractures. This was furthered by Garzan et al. In 1968. He had a case series describing the use of continuous mechanical ventilation as well as tracheostomy for severe chest trauma. These patients had multiple rib fractures, flail chest, as well as underlying lung injuries. Real learning points from the Garzan et al. Paper is that they were able to use the mechanical ventilation to describe the respiratory function of the patients and the decreased respiratory function. They showed that patients that had these traumatic injuries had decreased chest wall compliance, increased airway resistance, and they interestingly noted that patients that ended up surviving had increased airway compliance in comparison to patients that didn't. They were able to also monitor their patients' respiratory status with a fraction of absorbed carbon monoxide as well as ABGs. In the early to mid 20th century, there were some interesting treatments for chest wall trauma. This is for what they called stove-in chest, which we now recognize as a flail chest. The picture on the left here, that's actually a coat hanger hook that they screwed into the sternum and then applied to a weight to apply traction and lift the chest wall up. This weight, interesting, is hanging up over the patient's head. Likely represents some problems. And then on the left, you see they use a pair of clamps for the same, at least they're surgical clamps for the same purpose. This, you can recognize the problems with this. The patients aren't able to mobilize. They're laying bedbound, so questionable efficacy. The surgical intervention for chest wall trauma and rib fractures, the first description was by Charles Lock Scudder in the early 1900s. And he described open reduction and internal fixation of rib fractures using suture to fixate the ribs. This was furthered by Coleman in the 1950s, also ORIF, but used wires to hold the ribs in place, circumferentially wrapping them, creating a cerclage. In the 1970s, Paris and Judet advanced this with the use of plating, which were held in place with cerclages as well as struts. And then in the 1980s, Lubitsky introduced titanium plates that allowed for shaping to the ribs themselves. And then in the 2000s to present, you see that there's the introduction of commercial plating devices, really furthering the advances in surgical fixation of chest wall trauma. Learning points today, so relevant anatomy of the chest wall, as well as mechanisms and epidemiology of chest wall trauma, diagnostic strategies, and then management of non-operative versus operative management of chest wall trauma, and then indications and outcomes of rib plating. The chest wall is comprised of 12 ribs. You have 7 true ribs, 3 false ribs, and then 2 floating ribs attached to the sternum and the vertebra. The elasticity and compliance of the chest wall allow for respiration. As the external intercostal muscles contract, they lift the chest wall up and out and increase the volume of the chest, creating negative pressure, which allows air to enter the chest. On exhalation, at least passive exhalation, the compliance or elasticity of the chest wall allows for passive exhalation. The neurovascular bundle runs under the intercostal groove of the ribs. This supplies the blood supply to the chest wall as well as the innervation. This is just a cross-section of the intercostal groove demonstrating the vein, the artery, and the nerve running in the intercostal groove. This is applicable for intercostal nerve blocks. Rib fractures occur in approximately 10 to 20% of trauma patients. The higher the energy of the trauma, the more risk of multiple fractures, flail chest, as well as displaced fractures. Elderly and polytrauma patients are special populations that have increased morbidity as well as mortality. Associated injuries with chest wall trauma, most common is a pulmonary contusion. You can also get pneumothorax, hemothorax, as well as cardiac injuries or mediastinal injuries. Blunt thoracic injury accounts for approximately 8% of admissions to the hospital, for trauma admissions to the hospital, but accounts for almost 25% of the mortality of those trauma patients. So it represents a pretty big area for improvement, potentially. Mechanisms of injury, the vast majority in the 21st century are from MVCs because it's a high energy mechanism, as well as falls and crush injuries. In the elderly, the most common is from falls. They can also have iatrogenic injuries from CPR trauma. And then the energy transfer, so the more energy that's transferred to the chest wall, logically, the more injury to the chest wall. Rib fractures themselves weren't, unfortunately I had a good video there of paradoxical rib motion, but it's not showing, it's being blocked by our computer. Chest wall fractures were recently categorized, at least the displacement of them was recently categorized by the Chest Wall Injury Society into 3 categories of non-displaced, offset, and displaced. This is all determined by the cross-sectional overlap of the ribs. So if the overlap of the rib, as you can see here, is from 0 to 9%, then it's considered non-displaced. If it's from 10 to 99%, then it's considered offset. And then if it's greater than 100% of the width of the rib, then it's considered displaced. Unfortunately, we don't have a good categorization of the severity of displacement at this time. Comminuted fractures just have multiple fragments. And then a flail chest, as we all know, is described as greater than 3 adjacent rib fractures with fractures in greater than 2 places in each rib, which can lead to paradoxical motion of the chest wall, which decreases compliance of the chest wall as well as elasticity, so it causes hypoventilation of the underlying lung. Clinical presentation of these patients, they generally present with sharp, localized chest wall pain that's exacerbated by movement, breathing, and coughing. You might see crepitus over the ribs if there's, you can have bony crepitus. You could also have crepitus from underlying pneumothorax. If the fractures are severe, the patient may present with dyspnea. And then, as previously described, if they have underlying pulmonary contusions, they may present with hemoptysis. And then, elderly patients tend to present, they tend to underreport their symptoms, so it's something to watch out for. We've all had that little old lady that has one rib fracture that gets sent to the floor and ends up getting intubated. The pathophysiology of chest wall trauma and rib fractures, they cause pain, which leads to splinting, which is rapid, shallow breathing, unfortunately leading to hypoventilation of the lung tissue. This leads to an increase in secretions, which then leads to atelectasis as well as pneumonias. The same essentially can happen with flail chest with the paradoxical motion. As you inspire, the chest wall sinks in, and then on expiration, it bulges out and decreases the elasticity and the compliance of the chest wall, and then leads to hypoventilation and the same pathophysiology as risks of pneumonia and atelectasis. And then underlying pulmonary contusions are a major determinant of outcomes. So the more extensive the pulmonary contusion, generally the worse the patient does. Pulmonary contusions also lead to impaired, because of, the reason that is because they lead to impaired gas exchange. Modern management strategies, really the advent of multimodal anesthesia is the cornerstone of chest wall trauma management in the 20th century. It's a combination of utilizing NSAIDs, regional anesthesia, as well as epidurals, and then combining that with pulmonary toilet. So, positive expiratory pressure, things like that, IS, to increase the mobilization of secretions. And then, as well as additionally adding surgical stabilization to rib fractures in select patients, and then the initiation of institutionalized protocols further advanced rib fracture management. Diagnostic imaging, the first line is chest x-ray in the trauma bay. Can demonstrate underlying pneumothorax or hemothorax for the life-threatening injuries. But really the gold standard for chest wall trauma is getting a chest CT. It allows you to identify the number, the location, as well as the displacement of the rib fracture, as well as being able to visualize hemothorax and pneumothorax. Initial management of the patients, we follow the guidelines of ATLS, airway, breathing, circulation, disability, and then after all of that is settled, aggressive analgesia, respiratory support, as well as pulmonary hygiene and early mobilization. For the non-surgical management approaches of patients, really, as I said earlier, the cornerstone is pain control as well as pulmonary support. So you combine opioids, NSAIDs, plus or minus muscle relaxers, and then local regional anesthesia. Can be epidurals, it can be paraspinal blocks, it can be erector spinae blocks or intercostal nerve blocks. And then IV lidocaine has also been described, which and on a retrospective analysis is not demonstrated. It demonstrated no difference in pain scores, but did decrease hospital length of stay and costs, as well as opioid use. For pulmonary support, we use incentive spirometry, PEP, acapella, and chest physiotherapy. Those are all designed to help mobilize chest secretions to decrease the risk of pneumonias. And then CPAP and BiPAP if the patient is showing respiratory compromise. Patients should be monitored. You can monitor SpO2 for oxygenation, as well as their just overall respiratory rate. And you can use IS to monitor their respiratory function, as well as ABGs to monitor their acid-base status. ICU is potentially useful for elderly or multiple fractures, and it's institution based on guidelines. An interesting study out of Loma Linda and UC Irvine. It was a meta-analysis that looked in conjunction with East and CWIS, looked at 151 articles that looked at the non-op management and analgesic strategies in older patients. I think it was the age was greater than 60, and they found that the only intervention that had any effect was non-invasive positive pressure ventilation, and it decreased the risk of pneumonia as well as mortality. And then they looked at epidurals, and they had no effect on the rates of pneumonia, mechanical ventilation, hospital length of stay, or mortality. This is a nice cross-sectional image of for local regional anesthesia. So epidurals can be placed anterior to the ligamentum flavum here for epidural blocks. Erector spinae blocks are injected anterior to the fascia of the erector spinae muscles, and then paravertebral blocks are lateral to the transverse process, and these both target the dorsal root ganglion. And then intercostal nerve blocks go in between the inner and innermost intercostal muscles. There's several complications potentially from non-operative management. Patients can develop pneumonia, ARDS, respiratory failure, as well as restrictive lung disease. From a musculoskeletal standpoint, the patients may develop non-union or malunion or chronic pain. They may have increased ICU length of stay. Mechanical ventilation, morbidity may have increased costs. This is an interesting image out of Maddox's trauma. This is a 3D recon scan that demonstrates bony bridging between the ribs. So these were displaced rib fractures that were managed non-operatively. And they developed bony bridging between their ribs. This leads to restrictive lung disease patterns and dyspneic patterns in patients. So it's one thing to consider when managing patients that have displaced rib fractures. Indications for surgical fixation, CWIS and the World Society of Emergency Surgery released a consensus paper last year, including 287 papers that had a combination of systematic reviews, meta-analyses, randomized controlled trials, retrospectives, and prospective trials. They made 39 position statements that recommend the surgical stabilization of rib fractures as conditionally indicated in patients that have a flail chest, greater than 3 severely displaced fractures, severe chest wall deformity or instability, as well as respiratory derangements despite mechanical ventilation. Other conditional indications are failure of conservative management. So if the patient's been maxed out on their multimodal pain control, as well as pulmonary toilet, then they might qualify or benefit from surgical stabilization. Or if they have persistent or severe pain despite maxing out your multimodal regimens. Delayed repairs may be necessary if the patient has non-union or symptomatic malunion. And then they are conditionally indicated if a patient's getting a thoracotomy or a VATS for other reasons. So if you're already going to be in the chest, you should consider plating ribs while you're there. The main takeaway from all of this is that it's really conditionally indicated. It depends on the patient, and patient selection is critical. So with their conditional guidelines, this is the guideline, the algorithm that CWIS released with their paper describing when rib fractures should be managed non-operatively with, should be managed operatively. So they have their hard stops, their contraindications, so ongoing shock if the patient's hemodynamically unstable, if they have a severe TBI, if they're having an acute MI, or if the ribs are outside 3 to 10, it's not indicated. If they have chest wall instability, then you go straight to whether or not they have other injuries that have higher priority, and if they don't, then surgical stabilization, and ideally within 72 hours. They also state that if the patient has a failure to wean, then to take them to the OR, also within 72 hours. The EAST guidelines, they released a systematic review in 2017, included a systematic review and meta-analysis, including 22 papers. They conditionally recommend ORIF for flail chest, as there was decreased mortality, decreased ICU length of stay, hospital length of stay, decreased pneumonia, as well as tracheostomy. They state in their paper that these were, it's low quality data, but it's all of the data points were the same for all of the papers, and so that's why they're conditionally recommending it, but specifically for flail chests. There weren't enough papers that met their criteria to provide recommendations for non-flail chests. This is the current NGHS algorithm for management or triage of rib fractures in the trauma bay or ED. If the patient has one rib fracture and well-controlled pain, they may be good for discharge if they don't have any other injuries. If they have 2 to 3 rib fractures, they get admitted to the, or if potentially with 2 fractures of pain's control, they can go home. 3 rib fractures, they get admitted to the floor, and you institute the surgical rib fracture guidelines. And then we also take into account if they have greater than 4 rib fractures, we take into account their IS. So IS less than 20 can go to the floor, IS 10 to 20, look at their comorbidities, potentially ICU admit, and then IS less than 10, they get admitted to the ICU. This is our current surgical stabilization algorithm. It is similar to the CWIS algorithm. I've included a link at the bottom for the residents to be able to get to these. That link will take you to all of the trauma guidelines as well. This is our retained hemothorax algorithm. So if we have patients that are admitted to trauma team and we have suspicion for retained hemothorax within 72 hours after intervention. They recommend a CT scan and then drainage based on how much fluid is in the chest. I'm including this because we are updating this next week at the MTPRC, changing it just a few of the words. So instead of 72 hours after initial intervention, now it's admission, and then we're adding chest tube as well as intrapleural fibrinolytic therapy for complex collections, and then additional chest tubes for simple collections. These are SCORE guidelines to help evaluate whether or not non-operative management is successful in patients. The most comprehensive of which is RIB guidelines, the RIB injury guidelines, sorry. They include looking at age, IS, whether or not the patient has pulmonary contusions, how many rib fractures they have, if they have comorbidities, what their pain score is, and then weak or absent cough. A lot of these are limited by their subjective nature because they include cough and pain score. Preoperative considerations for rib fracture, surgical stabilization of rib fracture. So they should have multidisciplinary discussion between the trauma team and anesthesia, and then potentially thoracic surgery, depending what institution you're at. You should evaluate the patient's pulmonary function, whether or not they're going to tolerate the surgery. If they have contralateral pulmonary contusions and they can't tolerate lung isolation, then they may not be surgical candidates. Patients have to be hemodynamically stable to undergo rib fixation, so if they're hemodynamically unstable, then that's a hard stop. And then they have to be able to tolerate prone or lateral decubitus positioning. So if patients have unstable spine fractures, they need to be addressed prior to going to the OR. And then if you have it available at your institution, you should consider getting a 3T recon to help with operative planning. For surgical approaches, there's, traditionally it was open reduction, internal fixation with large thoracotomies. This has been changed mostly to mini thoracotomies, as well as the use of minimally invasive surgeries with VATS. If you're going to do an ORIF, you should consider doing a VATS as well to manage any hemothorax or any intrathoracic injuries at that time. There's different platings. There's external platings as well as internal plating. There's an interesting prospective analysis out of UC Irvine that demonstrated, that looked at internal versus external plating. They had 96 patients, 59 underwent external plating, and then 37 underwent internal plating. And the internal plating, they demonstrated a shorter hospital length of stay as well as OR time, but there was no change in ICU length of stay or opioid use. These are different proprietary rib plates. It's RibFix Blue on top, RibLock is the second one, and then Matrix Rib, Nitrib, and Stracos. These are all external plates that are held in place either by cortical screws or struts with screws. Potential benefits of surgical stabilization of rib fractures. Potentially, the patients may have a decreased duration of mechanical ventilation, decreased ICU and hospital stay, potentially decreased risk of incidence of pneumonia. They may have better pain control. They may have a better rate of mortality as well as tracheostomy. A systematic review out of Stanford published in the Journal of Acute Care Surgery and as well and a Bayesian meta-analysis demonstrated that the surgical group had 2 to 7 fewer ventilator days, 5 to 7 fewer ICU days, 8 to 12 shorter hospital days overall, and then a 15 to 85% decreased risk of tracheostomy, 25 to 80% decreased risk of pneumonia, and then a 35 to 85% decreased risk of mortality. It's pretty interesting. And then Hisamuna et al. Released a meta-analysis comparing operative to non-operative management of rib fractures, and they found no difference in mortality, but they did find a decrease in mechanical ventilation as well as ICU stay with surgical stabilization. And then in 2022, a meta-analysis out of the Royal Brisbane Women's Hospital of 40 papers found a decreased ICU length of stay, decreased mechanical ventilation, decreased rate of mortality, pneumonia, and trach in patients that underwent surgical stabilization. They found the patients that most benefited were those that had flail chest and those that were operated on within 72 hours. They also found that the hospital length of stay was shorter for the non-operative if the patients were greater than the age of 60. There's some randomized controlled trials performed for surgical stabilization versus non-operative management. So Tanaka et al. In 2002 published 37 patients randomized controlled trial utilizing Jade struts versus mechanical ventilation. And they found that stabilization had reduced vent days, reduced rates of pneumonia, reduced rates of reduced ICU length of stay, as well as hospital costs. Interestingly, they made their determination whether or not to do their surgical stabilization at 5 days. Silvana et al. In 2012 did a randomized control trial with 46 patients looking at Surgery versus no surgery in flail chest, they found that they had a shorter ICU stay, less non-invasive positive pressure after extubation. But they found that the follow-up at 6 months, there's no differences in quality of life or differences in spirometry. Garikopoulos in 2017 in the Journal of Trauma did a randomized controlled trial with 83 patients. They had a marked decrease in the length of stay. It was 14 versus 30 days for the surgical group. Decrease to 48% ICU admissions versus 77% of ICU admission. And then a decrease in mortality, 2.1% versus 13%. Tao et al. In 2019 had 50 patients in their trial. They showed fewer vent days, ICU length of stay, decreased rates of ARDS as well as pneumonia, and then an improved pain score as well. Dangan et al. In 2022 published a randomized controlled trial in JAMA. It's the largest randomized controlled trial to date that looked at non-operative versus operative intervention, and they had decreased mortality and length of stay as well as vent days, but they found that this benefit was only if the patient was ventilated preoperatively. All of these studies look specifically at flail chest or did not differentiate between flail chest and displaced rib fractures. Parachi et al. Published in 2016 a retrospective analysis looking at surgical stabilization of rib fractures, specifically in non-flail rib fractures. They found that they had a decreased respiratory failure, 5 fewer vent days, and then decreased tracheostomy in patients that underwent surgical stabilization. And then Wu et al. Published in 2015 a randomized controlled trial of 150 patients. And they found that they had fewer vent days, severe hospital length of stay, as well as ICU pneumonia and mortality in patients that underwent surgical stabilization. But these really are like the only papers looking at non-displaced rib fractures. There's a dearth of information for non-displaced. The vast majority of papers that have been published so far are for flail chest segments. In the EAST guidelines, as I said earlier, they conditionally recommend surgical stabilization of rib fractures due to those benefits of decreased mortality, mechanical ventilation, hospital length of stay, as well as ICU length of stay, but state that it was low quality evidence. They only had 3 randomized controlled trials in their study. Timing, when to operate. Paper out of UC Denver demonstrates early stabilization. It was a systematic review, unfortunately. It wasn't a randomized controlled trial, but it demonstrated that operating within 48 to 72 hours is associated with a shorter hospital length of stay, shorter ICU length of stay, less days on vent, as well as lower rates of pneumonia and tracheostomy, and interestingly enough, lower hospital costs. So despite the cost of surgery, they had lower costs with intervention. Absolute contraindications, as discussed earlier, hemodynamic instability, extensive pulmonary contusions not allowing for ventilation, as well as if the patient is a poor surgical candidate. Active infection is also a contraindication because you can have infection of the plating, the hardware. And then ribs 1 to 2 and 11 to 12. So really only 3 to 10 are the ribs that are able to be plated. It's a case study here at Gainesville. It's a 79-year-old male that was transferred from an outside hospital for a ground level fall. He was found to have left 7th or 11th rib fractures, as well as hemothorax and pneumothorax. Received a chest tube in the trauma bay. Was admitted to the IMCU. His IS on arrival was 18 cc's per kg. Unfortunately, I couldn't get a 3D recon of this, but you can see hemothorax there, and then marked displacement of the 7th, 8th, 9th, and 10th ribs. Patient was initially scheduled for OR on hospital day 2. Unfortunately, had to be canceled because he had AFib with RVR and hemodynamic instability. Eventually taken to the OR on hospital day 3, undergoing a VATS as well as ORIF of ribs 7 through 9. This is CT post-operatively. You can see really good reduction of the fractures as well as the external plating there. Does have a little bit of hemothorax or atelectasis there. He had, unfortunately, they left 2 chest tubes in the operation, but the patient still had a retained hemothorax post-operatively and required a pigtail chest tube. But the patient ultimately did well and was discharged home on hospital day 18. The key takeaways from this, rib fractures, especially in elderly polytrauma patients, carry significant morbidity and mortality. Pain control and pulmonary toilet really are the cornerstones of conservative management of patients. And then there's the potential that surgical fixation may improve the outcomes in select cases. It's not a one-size-fits-all for everybody. It really depends on the patient. Pitfalls, underestimating isolated rib fractures in the elderly. As I said earlier, if the little old people are frailer, they have a tendency to underreport their symptoms and can do poorly, unfortunately. And then also delaying surgical intervention. If you're going to operate, you should operate within 48 to 72 hours. If they have a contraindication that's able to be fixed prior to the OR, then you should, and you need to delay, then it should ideally be done within 3 to 7 days. So these are just some interesting discussion questions to ponder whether or not you should plate for displaced rib fractures in a patient that has pulmonary contusion. It really matters how clinically how they're doing, if you think they can tolerate being ventilated or if they are failing non-operative management. Our hospital uses epidural anesthesia as part of our algorithm for rib fractures. I've seen the order for ESP blocks, but I've never actually used it. And then yes, our trauma protocol does include early surgical evaluation for consideration of rib fracture repair. And so we've pretty much discussed this, but factors influencing considering surgery. So it's the flail chest versus displaced rib fractures, and then whether or not you've exhausted your non-operative management. I think if pain is the 5th vital sign, then if the patient has totally failed non-operative management, you've maxed out everything, and they still have persistent pain or severe pain, then you should consider surgical stabilization. Yeah. This really comes down to, what you have available at your hospital and what constitutes severe displacement of rib fractures. Unfortunately, at this time, we don't have a good algorithm or a good criteria for what is severe versus non-severe. This isn't really, plating versus advanced analgesia. It's not an either-or thing, really. Surgery is in conjunction with this, so you can maximize your multimodals prior to considering surgery. And is rib plating cost-effective? There's been a couple of studies. One is Coleman et al. Out of UC Denver in 2020. It was a retrospective chart review, so not perfect, but they looked at patients that had greater than 3 rib fractures and underwent either surgical stabilization versus non-operative management. They controlled for patient demographics, injury severity score, as well as concomitant injuries. And they had a calculated cost savings of $14,000 per patient that underwent surgery versus non-operative management. So it could potentially be cheaper. So in summary, chest wall management has advanced significantly in the last century. Modern care is the cornerstone of which is analgesia, pulmonary toilet, new imaging, and then selective surgery in selective cases. There is a need for further classification of displaced rib fractures so that we can create trials to look at whether or not patients with displaced rib fractures would benefit from surgery. It's not clear at this time. Thank you.
Thank you so much, Dr. Higgins. Does anybody have a question?
Good presentation. 2 points and/or questions. One, just a point to consider when you're thinking about rib repair. Anecdotally, I typically don't use pain as part of my algorithm. I find that the patients with chronic pain and untreatable pain are still untreatable post-op. So I just typically use chest wall instability, displaced rib fractures, things that you really think are not going to heal well. On a pain note, did you find any evidence or any algorithms or anything to support which blocks work? What should we be using? When should we be using it? I think that's an area that we could probably improve on, or probably everybody could improve on. Did you find anything?
Yeah,
Data?
I didn't find any. I found one paper, and it looked at the use of non-operative pain control in the elderly, and they didn't have any good findings, other than just using non-invasive positive pressure ventilation for internal stabilization. I didn't find any good papers that really looked at local regional anesthesia.
Gotcha. Yeah, I think we've used a few ESP blocks, some epidurals, but it's very hit or miss. And for anybody that's interested in maybe trauma, that's probably a ripe area for some research, especially with our radiology switchover. That might be a nice ripe area. But we've had some just a hard time getting people to buy in for doing paravertebral or ESP blocks from an anesthesia / interventional radiology perspective in the past. So maybe that's something we can change in the future.
I discussed it with anesthesia, and the anesthesiologist I discussed it with didn't even say that they do paravertebral blocks here or ESP blocks, so they only do epidurals.
Yeah, I would agree with what you found. I think there's maybe one or two of the anesthesiologists who've offered to establish that as an option that have serially been squashed by the other 98 anesthesiologists that work with them in terms of willingness to do that. So it's a, no pun intended, kind of a pain point. Just a couple of emphasis points for the group. One, I would say Chest Wall Injury Society is, if you're interested in trauma and acute care surgery and want to really have a really, I won't say easy, but very accessible avenue into research and national organizations and presentations, it's probably one of the best, because it's all of the names that you saw in those papers are attend this meeting every year. There's 2 meetings. There's one that's in the States and one that's usually somewhere in Europe, which hopefully is a little bit of a carrot to get on the program, because you get to go to some cool places. But really ripe and fertile area for research if you have those interests. It's a great society to be a member of. So I'll put in a plug in for that. But I think one of the things we found, and I hope I certainly got out of the presentation, and Sean did a very good job of, is the idea that, well, really 2. One, our traditional management of chest wall injuries has been the same as the Egyptians mentioned: do nothing. The patient will do what the patient will do, and there's nothing we can do about it. I think that still is in the back of the minds of a lot of practitioners today, is that, well, there's really nothing we can do to improve it. And that's not necessarily true, especially when you talk about management of hemothorax, because that's one of the reasons we're modifying that guideline is to provide a framework for us being more aggressive and appropriately aggressive at managing hemothorax. But the other point is there's an art to picking who's going to benefit. I think Dr. Gibson hit on that point. There's an art to picking who's going to benefit from surgical stabilization of rib fractures. We didn't do it for decades. Then we started to do it, and then we did it for everybody. It cost too much, didn't help the majority of people, and now we're kind of falling back into okay, how do we pick those patients? And that study by Piracci is kind of the landmark that Chest Wall Injury Society has built their recommendations on, and then we've incorporated those in our thought process. But it isn't just pain and displaced rib fractures, it's pulmonary derangements. If I have somebody that's popping and clicking after 4 days and we can't control their pain, maybe that's somebody that I might offer that to, but with the stipulation of this may or may not move you forward, but we're not going anywhere right now. But pain alone, especially in that chronic pain patient that's been taking Lortabs for 10 years, probably not the best sole indication, but really good job at presenting kind of the depth and breadth and the history of how we treat chest wall injuries. I would just put in a plug for CWIS.
Thank you. We have another question over here.
Hey, Sean, thanks for the presentation. So one thing that we ran into, like I think this was last year, with some of these patients is pulmonary contusions and where they fit into the protocols and algorithms. In your opinion, after looking at all this stuff, do you think every rib fracture protocol guidelines should include a stipulation about pulmonary contusions when they stratify patients, or no?
I think it's worth at least considering including it, at least, when you get to that part of contraindications, whether or not the patient can tolerate the surgeries is pretty important. But there are patients that have respiratory derangements from the pulmonary contusions as well as rib fractures that may benefit from the surgery, so, yeah.
Do we have, we have another question back here. Get this too.
So just to add on, talking about pulmonary contusions, I think it's important to look more so which side your contusions are on. Because remember, when we do this, patients are, they're in lateral decubitus, single lung ventilation. So if you're working on the left side and they've got a bunch of contusions bilaterally, that's the patient that may not tolerate the procedure.
Okay, looks like that's a wrap. Thank you so much, Dr. Higgins.